Thank you very much. And initially, before my new job, when Ronan asked me to speak, I assumed that I'd probably talk about something about breast cancer. But then I realised that anyone who's interested has heard it all before, be it at the NCCP or a Charter Day at any of the other various meetings. So it made me all nostalgic, actually, coming to the matter, and reminded me of being here as a student sometime in the mid-late 90s, or we won't really dwell. And I was working, first research project with Professor Gorey, and then came back as a tutor under the late great John Fitzpatrick. And there's a nice symmetry here, because my first job as head of school was the transitioning ceremony for our students who go from preclinical to clinical years, where we hand out their lapel pins, since they're not allowed, courtesy of infection control, to wear white coats anymore. And our guest speaker at that was Professor Wood, who actually was my supervisor for that very first surgical project. So kind of all started here and has a little bit of symmetry related to it. So as part of the new job, I've been encouraged to read a lot of new I suppose, information about management, and articles I would have avoided like the plague that involve phrases like stakeholders and clients rather than patients and students and colleagues. Articles I'd normally be very adverse to, but this is one that struck me from two physicians who actually head large healthcare centers in the US, and they wrote about Harvard Business Review. And they say that now physicians are deeply anxious about the changes underway and are mourning real or anticipated losses of autonomy and respect. And they're moving at various rates through the stages of grief. A few are still in denial, but many are in the second stage of anger. Bursts of rage over relatively small issues are common. I'm wondering if this is gaining any traction here, because as a surgeon, you see, if you leave us alone and put us in an operating theatre, we're usually happy as a clam and don't get into any trouble, not with our colleagues at least. And this is a weekend on call where you have a bowel obstruction and an unfortunate 30-year-old for the fourth time off his quad bike. I really think he hasn't learned. Or better again, on a Monday morning where you get to do your specialty interest and you have bilateral breast reconstruction with autologous tissue. And that's all very well, but there are massive changes coming to our practice, and it makes us wonder what stage any of us are at. Is it the denial that you experience in the I'm all right Jack phase, where you still have your operating list and you can carry on regardless while seeing some changes around you? But is this before your theatre list is closed in a 1 in 3? While you see your trainees greater than 40% of the week, when you still have access to some of the surgical beds that don't have medical patients in them, and before your clinics, rounds or lists, insert as necessary, are overrun by medical students, as I hear my colleagues from. Perhaps you've reached the anger phase, and this may be precipitated by usually a hospital meeting where someone calmly explains that your list or beds have been removed or cancelled or not reinstated, and in the same breath casually ask what you're doing with the outpatient waiting list and how you're going to deal with it, to put all those patients from the waiting list onto yet another waiting list that may never yet happen, when you're told with a shrug that there cannot be any more nurses appointed because there are none available, and yet you know that the graduates from your own university are leaving the country because they can't find employment. Or perhaps it's yesterday, where you listen to the radio on the way home and you hear in the Dáil your local TD has described your hospital as not fit for purpose and has invited Taoiseach down for an impromptu visit to solve all the problems. Or perhaps most worryingly of it all is when you see one of your own consultant colleagues vilified in the media and scapegoated by local management for problems and bad outcomes that they have had no control over. But then I remember Professor Sean Tierney saying at a meeting that if you're not going to negotiate or sit down at the negotiating table, you better take an axe to that table to make sure that no agreement is made when you've left it. And so many surgeons have become involved in hospital management, often through the directorate process. And this has had varying degrees of success, because as long as you have some level of control with regard to resource allocation along with responsibility, and don't just become a conduit for bad news, this isn't a recipe for success. And we are required to have an increasingly high level of activity at a very high standard, but on an ever decreasing pool of resources. And perhaps is indicative of the situation now that 25% of all our approved consultant posts had no applicants in 2015. People are concerned now not just about the general public's mental health, but also perhaps our physicians' mental health. This is a particularly startling systematic review of all studies related to burnout, particularly for those in a career in surgery, demonstrating about 12 to 58%, and issues with litigation, overregulation and defensive practice are significantly adding to this. And so it's come to the attention of our regulatory bodies, probably not before time. They've already, the Irish Medical Council has already looked at burnout in junior doctors, and now they're increasingly going to look at that along a more senior clinicians. And this is probably reasonable because they may represent part of the problem. 4 to 6% of doctors die whilst undergoing fitness to practice investigation. In the UK, in the General Medical Council, 28 suicides occurred in a group of 114 doctors who were under investigation. And so this has resulted in a lot of disengagement from clinicians, not just with our regulatory bodies, but also with hospital management and perhaps even with our training bodies as well. When one feels that one's voice is not heard, it can result in acceptance. Is that the final stage, or could it perhaps even be apathy? Aristotle says that the last vestiges of a failing society are tolerance and apathy, but maybe that might be too catastrophic. So where do we go from here? Do we do absolutely nothing and hope that everything gets better? Well, the next slide is definitely not magical. It may be dreamlike, and perhaps some might see it as a nightmare, but 2016 has not been a predictable year so far. 6 months ago, very few of us would have predicted Brexit or Trump. And indeed, when you look at two individuals that I can guarantee, I hope I don't identify myself with on this particular slide, I hasten to add. But if you look at individuals of perhaps limited understanding, buffoons perhaps, would you ever have imagined that they would have been the winners of 2016? And perhaps this is indicative of not necessarily their, I suppose, qualities, but perhaps a protest vote for people who are looking for change. And maybe this can be brought back to ourselves, that maybe acceptance or silence isn't perhaps the answer, and maybe it's time for us to take back our profession, starting from the ground up, particularly with regard to education and training and people's views on professionalism. And these are words that are thrown out all the time, and increasingly by individuals who don't look after a patient and don't actually do the job involved. We need to look at how we deal with the Medical Council and promoting leadership from amongst our own colleagues to improve the outcome for those coming after us. We all know this particular paradigm. It comes from the Medical Council, the 8 domains of good professional practice and patient safety, and we refer to this, I know, in the medical school, particularly around accreditation time, about 20 times a day. But one of the slightly irritating aspects of this is the concept of patient safety and quality of patient care, in many cases, has been overtaken by those who are not actually delivering that patient care, and they've almost taken ownership of quality as if it was theirs and not ours. And you can put many different bodies, including HICWA and others, in that group. You see that communication is being taught by communication experts, and professionalism by psychologists and pilots and even ex-military in certain institutions, amongst a whole range of human factors that are not necessarily that relevant, I would say, to clinical practice. The most useful discussion I've heard on professionalism came at the Frere this year from Professor Martin Corbelly's tour de force state-of-the-art lecture, and I would advise anyone who was not lucky enough to watch it to download it, which you can on Vimeo. It was an astonishing display, really, to be honest, where he described, this slide is taken very much from his talk, and over a career, it describes professionalism. I think we would probably understand it. It's easy to recognize. It's patient rather than disease centers. It improves with experience. So the most experienced clinicians should probably be those who advise most on what professionalism actually means, rather than those who necessarily may have experience in psychology or medical law and ethics. It has responsibility and accountability, but not necessarily responsibility for things that you have no control over. It does not increase or improve with regulation. And most startling of all was his discussion of resilience and altruism, which, despite adversity, is something that he is very much an exemplar of. So perhaps when we're looking at teaching our trainees and our medical students, we need to look outside the traditional places like the operating theatre. So this is my team. These are our two interns, Brian and Anya, with our SPR, Tom Ahern, in the centre. I made them do the Galway Bay Half Marathon with me. You could say improving work-life balance, you could call it bullying, you know, but this demonstrates a whole range of different skills that are not necessarily in the operating theatre. Tom, who's a fantastic SPR, demonstrates communication, leadership, team building, mentoring, as he's even helping the poor intern put his number on because he couldn't manage the safety pins himself. But then we're again looking at other ways of teaching when we don't have access to the endoscopy suite or the operating theatre. We've embraced simulation, which I know most institutions have at this stage. Where we're attempting here to snare the polyp, and then something crazy happened and they let the breast surgeon have a go. And I can only say, thank God, in this picture I am actually holding the endoscope the correct way up, because I only get one endoscopy list a month, but there you go. When it comes to bowel anastomosis and serious colorectal work, we do, as you see, get some proper surgeons involved, and with Joe Garvin and Miles Joyce. And these workshops take place on site, make it close to where activity is actually happening. If we can't even get into the operating theatre, we'll at least make the simulation on site where people can leave their clinical activity for an hour. We bribe them with pizza and buns, and it allows for not just the technical skills to be delivered, but also the mentoring and the face-to-face activity, which is sometimes missing when you have so many cancellations and such a disconnect between activity and training. The orthopedic surgeons obviously have to get involved, and without wanting to have too many cliches, as you can see, they actually brought their own power tools, which is not surprising. As you can see, Mr. Devitt looks slightly scary in that particular photograph, holding an electric drill, and so someone thought it was a better idea to stabilize him in a cast before he did anything dangerous to anybody. But this slide always comes up when I'm at one of my new management leadership skills courses, where the clinicians are usually accused of not wanting to change, that we're the establishment, and I actually think the opposite is true, that in the bottom group, surgeons are frequently the ones who embrace technology, embrace new ways of working, and this is very much the case in simulation and in new ways of education and teaching. And perhaps also we need to look at how we continue to allow that change to happen, and in leadership particularly. It's vital that surgeons are involved in leadership, but obviously surgeons are busy people, and this has to be recognised and appropriate backfill, and perhaps looking at a mechanism where people, if they take on a leadership role, that it doesn't mean the end of their career. I think it's always been a problem that if people are making decisions with regard to education and training, at the end of their career, they're not working to deal with the consequences of those decisions. They're not on call, and they're not dealing with the results of changes in a training program that may or may not have been successful. Therefore, if you want to be either in hospital medicine or in any form of education, I think you need to maintain clinical activity to maintain credibility, both with students and with your colleagues. And that's all levels of clinical activity. Perhaps if we want to increase engagement, we need to think about devolving the training program so that people have greater control, not only over how their trainees are allocated, but the whole process within it. And if people are going to become involved in education and training, this should be recognised. It's not something that should be done, as always, routinely and for free. I don't just mean in monetary terms, but I mean also in recognition. So I don't believe that the clinicians have left the building. I think they've moved into different parts of the building. I think they need to be recognised for that, and that needs to be made easier. But everyone realised that surgery is very much for the long haul. It's always been more of a sprint than a marathon, but it's always going to be rewarding. So I'll just keep to time and leave to that. Thanks, Ron.